We've talked about VEGF. It's made by activation of hypoxia-inducible factor. TGF-beta-1 is also made by induction of HIF. They turn on gene transcription, so there's going to be an initial rise of VEGF very quickly with exposure. So in re-exposure protocol patients, you'll see VEGF going quickly, but then as TGF-beta-1 is made, there's a fall in VEGF. So if you look at day 1 on a re-exposure protocol for a mold patient into a building, VEGF rises and then it crashes by day 3. So this feedback interaction of TGF-beta-1 is pretty important. Now, we talked about VEGF in chemotherapy, we talked about low VEGF in biotoxin people. I pretty much in my patients see a U-shaped curve, a lot or less than 31, and not too many normals, and then some are over 86. The normal range for our lab is 31 to 86, and when you see 0 to 115 from LabCorp, for example, or from Quest, just grain of salt, just remember that's not logical. The question comes up for mold patients when they're exposed to known cancer-forming cells. Lots of mycotoxins are carcinogenic, and I expected to find more cancer in my patients than in other protocols. It's just the reverse. I find fewer breast cancer patients, I find fewer lung cancer patients, I find fewer colon cancer patients, I find fewer people with hematopoietic malignancies. And I don't have the answer for that. I just think that low VEGF from things like fumagillin is protecting them. I don't know. Do not ignore low VEGF. In your approach to treatment, it's not one of the first things you do. It's after you've eliminated coagulating staph, after you've lowered MMP9, but you really do have to correct low VEGF. VEGF has a lot to do with delivery of oxygen in capillary beds, and quite frankly, you cannot measure oxygen in capillary beds using arterial or venous blood gases. I know some doctors like venous blood gases. I don't. Specifically, I will use measurement of VO2 max, doing pulmonary stress tests, or better yet, measuring lactate in MR spectroscopy.